Good evening, Facebook family and friends. I'm Cathy Novicky, and this is my 90-day Facebook Live. Today is Wednesday, July 19th, and it is day 55. I'm sorry, my son just walked in, so I was going while he was walking in, and he's now giving me the dirty look. Hi, Jared. Hope you had a good day. So while I was late last night and looked like just been run over by a dog or several dogs, I'm late again, but I'll tell you why. I sat down earlier to write, to put down some thoughts on what I was going to talk about tonight. And what I ended up doing was I ended up writing my speech for Toastmasters that I have to do next Wednesday. And once I got into it, I really didn't want to stop because I was on a roll. So I finished that. It needs obviously to be tweaked a little bit, but I'm happy with what I have and the direction that I was going with that. So then I had to say, okay, but now I have to do my live, so that is the what to do point. But what my thought was, it was a conversation that I had today, and it's a conversation that I have, I don't want to say all the time, but it's not unusual to have this conversation at work. And what the conversation is about healthcare decisions. There's the whole spectrum of people who, from I don't want to talk about it at all to, okay, here's my advance directives, and here is all my wishes down to the last bullet point, and that's very reasonable because everyone is unique and everyone is different, so they're going to come to you with different perspectives. But this is an example of scenarios that I have been involved with, unfortunately, more than once, and as a healthcare provider, it is probably up there amongst one of the worst situations that you can find yourself in. And as a family member, per se, it would be one that I would avoid at any cost. So let me explain it to you. You get a very critical patient, whether it's from the emergency room, whether it's from a medical surgical floor. They send this patient to an ICU because they've become unstable. And so the patient arrives and you start doing things. And they might be awake and you can talk to them and try to attain their wishes. I mean, you are very clear with you're very sick and, X, Y, and Z may happen. Do you have any thoughts on what you would want us to do? Have you ever talked to your family? And this is in between doing, all of the physical things, all of the assessments and orders that you're doing. And it's a conversation, but you're just trying to draw tidbits out of someone who's very, very sick, and just to try to have some idea of where they are, what their mindset is. So hopefully there's family available, and if they get there And so the doc goes out to talk to the family. And they're out in the waiting room. It's a room, it's closed doors, they're having a conversation, and the doctor's laying out what's happening and what could potentially happen, and asks them the same question. Has your dad, has your mom, has your grandmother ever expressed wishes for what they would or would not want when they were at end of life? And sometimes you get yes, and and you talk about it. Sometimes the family just has no idea what their loved one really wanted. They didn't want to talk about it, either whether it's the patient or the family. It's very hard to talk about your mortality, and as someone who has had a life-threatening disease, I understand that. And at 47, it's even harder to have that conversation, in my opinion, because at 47, you're not supposed to get those kind of illnesses. You're not supposed to have to deal with those kind of, situations. But, that's the selfishness in me coming out. I have to pronounce my words a little better because it's a little later. So, and it never goes the same way twice with families, because if it did, that would be way too easy. Not that it's easy, but coming from the professional doing this kind of work for 30 years, it's you see it. You see a lot. You see too much sometimes, and you pretty much have seen it all. Not much surprises me. But the worst part, you thought I was done, right? The worst part is when you have to break into that conversation because the patient has become even more unstable than they were before. Hence, you think that that could possibly happen. Yes, it does. And what you try is you try to hold off doing that and giving the physician as much time as they possibly can get to help work a family member or members through that decision process. But I have had to break into those conversations and say to the physician, I need you now. And basically what it means is I am calling you and I'm pulling you in, because if we don't do something right now, the patient is going to code, meaning A, they're going to stop breathing and then their heart is going to stop, or B, their heart is going to stop and then they're going to stop breathing. Irregardless, you or we are going to have to intervene and be aggressive, because I have no order not to be. And the very sad part of, well, there's many sad parts of that. The sad part is that you've left a family member or members in the waiting room with a deer in the headlights look. They look like this, right? And I'm not being sarcastic or funny. That's how they look when you do that. And they're frantic, and they are absolutely in crisis mode, because the conversation has never taken place before as to the wishes of an elderly, hopefully elderly person. And so, inevitably one of two things happen. Either the doctor will turn to them and say, okay, I have to go. Do you want me to do this, or do you want me to not do this? Now, to have to make a decision in frantic, in crisis mode, point blank, like that, I can tell you it usually is just do everything for now. Because what else are they going to say? And then that just leads to other issues. But when the body physically gets to a point where it is at that phase where it's going to stop, their breathing is going to stop, or their heart is going to stop, it usually means that the body is done. You know, you have fixed the engine. I explain to patients and families, you know, the body is like an engine. It's like a car. You only can fix and replace parts so often or so many times and tweak, you know, and adjust until it gets to the point where the motor is going to give out and you can't fix it anymore. That is very simplistic, and please do not take that to mean that it is without feeling that I say that. I just say it in a very straightforward way because it's an understandable a scenario that people can understand better than getting into all that medical-y stuff, you know. But it is. The body is only going to work for so long, and you only can sustain it for so long. And in the scenario that the specific one that I am recalling, that this happened, what I'm referring back to, that is exactly what the family said, do it. And we went in, and luckily the only thing we had to do at that moment was intubate the patient, which meant we had to put a tube into their lungs or into their trachea to breathe for them. We were able, and for me, I call that being proactive. You may think, ooh, proactive, that's absolutely reactive. But in medicine, being proactive, it means intervening before something lethal happens. And she had not stopped breathing yet, so therefore it was proactive. And it's a very fine line you walk. So this lady was intubated, but then bit by bit we had to start adding treatments and things to sustain her body, fluids for blood pressure, and then medications for blood pressure. And so this is telling medical professionals that, okay, you're helping her breathe, but now the other parts are failing, because that's how it happens. And so at this point, this woman was still not, a DNR, which means do not resuscitate. And if I can get this to one person to understand, when a person is a DNR, a do not resuscitate, and they come in to the hospital as a DNR because those are their wishes, because they've had that discussion with their family, and they have done the legal, the advance directives, the legal documents, and they want to be a DNR. They do not want to be resuscitated. That does not mean that we don't treat them. We do, to the extent of their wishes. If it's something that they can get over. I mean, it happens every single day that people are admitted to the hospital for condition X. We treat it, and 3 or 4 days later they go home. They're still a DNR. They're DNR at home, but their condition with which they were admitted for has been treated. So in no way do we not treat or just push DNRs into the corner. Okay. And medicine has, over the past couple of decades become very, very good at talking to their patients, their clients, about, if you have a relationship with a primary care physician, they over time learn to know you, know your personality, know how you normally react to things, what you usually choose, and they usually have a very good handle on what a person would or wouldn't like. But the way that hospitals work now, they're in the hospital, the physician that sees a patient is a hospitalist, meaning they're a physician, but they work in the hospital. They're employed by the hospital. So they don't necessarily know this individual for 20 or 30 years, so they don't know what they would wish. And I know that's another topic. I can get off topic really easily. But back to the scenario that I was talking about, the family did not give any more wishes. The patient was still a full code. And I will never, 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 never forget the physician turning to me. I had asked a question or updated him on something, and he said to me that the patient will tell us, meaning the body will tell us, in the next couple of hours what's going to happen, how it's going to go. Because as I said, when the person, when their organs or motor parts get to that point, you can't fix them anymore. And so he said this to me, and about 15 minutes later, the woman died. Or actually, no, I'm sorry. About 15 minutes later, he had said that, and I barely had gotten back into the room, and I came back out, and I said, I think she's starting to tell us now what's going to happen. And I think at that time the family was still present. They had come in and saw her and then went back out, and I think they had a conversation amongst themselves. And when I said, I think she's starting to tell us, that at that point the physician got a DNR order, and we just made her comfortable, meaning we gave her medication so that she wouldn't be in pain, so that she wouldn't struggle to breathe, and the nature would take its course, and she passed away. Now, she passed away without us doing CPR, without us having to use electricity on her to get her heart started again. And I'm very happy for that. But the point I'm making is that to have to pull a physician out of a conversation in that high tension, stressful environment is a disservice to the patient, and it's a disservice to the family. So my plea is have conversations before situations like this. I know it's hard. It's hard, and everyone has different feelings, different emotions on how to talk about it, how to start a conversation. I mean, you always can ask a physician, or have a family meeting with a physician if the parties, meaning the patient and the family, don't know how to do it or can't do it. Because a physician is trained to have these kind of conversations, and they know the patient, they know their personality, they know their medical issues, and they'd be able to present them to the family in such a way that as neutrally as possible, and at least get that conversation started, because there are a couple of issues that will come out of the scenario that I described. They say, yes, do it all. And we do it all. And, you know, the standard of care, the standard of practice for whatever scenario was, we followed, and the patient still died, say. So now we've gone back to the family, and physician tells them we did everything, you know, blah, 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 and I'm very, very sorry, but your loved one has passed away. So now, on top of grief, hopefully, I mean, sometimes I wonder, you know, about my children. But anyway, that must just be the fact that I'm so tired. But, you know, they have this sudden, you know, horrendous grief. And then, is there guilt that they put their mother, their loved one through? I mean, I don't know if anyone has, you know, what's on TV? Forget it. It's as far from real life as you are ever going to see. Doing CPR and heroic measures is, I call it, from what I see, it's a humiliating situation. Now, you say, okay, well, does the patient realize? You never know, you know? I have had a patient who we were intervening and he woke up. Now, I'm very, very glad that he woke up. It's unusual. And he was thankful he woke up, and he survived. I mean, I don't know where he is today, but on that day when his body was giving out due to a very specific reason, which was reversible, and please, CPR is, you know, when that body gets to that point, it is, well, it's good to know it's not usually reversible. You know, it takes a lot. So anyway, all right, so back to this. So then you have grief, and then guilt. Did I do this to my parent, my loved one? And what do I do now? The flip side, if you say, okay, you know, what the doctor has said to you in this very horrendous, frantic crisis mode, let's just let them be comfortable, keep them comfortable, and let them go. Well, then yes, there's, you know, if they pass away, there's grief, but then is there guilt? Should I have intervened? You know, and so neither, in my opinion, suggestion or decision is at that point going to give you any comfort. Now, obviously, acute grief, there is no comfort in that. But what I explain to patients and family members is, if you've had these conversations, if you have put into place advanced directives and wishes, you have taken those decisions away from your children or whoever is going to make decisions for you. They don't have to choose. So while it might not make a difference at that point in time when that individual passes away, it was a gift that they made you aware or involved you in a conversation that their wishes were known. And it was a gift on your part for following them, because they passed away, they died on their terms. And we call that a good death. And you might think, what is she, crazy? A good death? But you know what? Nobody gets out alive. We all die. We're dying from the minute you're born, you're dying. Then you might think, boy, she is one sick cookie. But, you don't think about it, but it is really the reality. We age every day. Do you want to see these gray hairs? No. Now I'm really delirious. But it's the truth. It's the reality of our lives. You're born, you grow to a certain point, and then, year by year, your body changes in the other direction. And, if you think you're going to live forever, I really don't want to ever take care of you as a patient, because we would clash very badly. And you're just, it's just not how it is. So to be able to give a family a good death in years to come, in however many years it takes them as an individual to get over that acute, crushing grief, and find a place of, where there's grief, but it doesn't overwhelm you on a daily basis, and you look back and you remember more of the better times or the happier times, or when a person was healthier, and that makes you smile, and that, it's a good memory. That's what I mean by a good death, because there was reciprocation between two parties, that you had a plan and you both followed through on that to the ease of a very difficult situation. So I won't rant and I can't even think of the word, preach, that's a good one, about what you should do. But I strongly advise that if you don't have anything in writing, at least have a spouse or a partner or a child know what your wishes are. It's harder then because they don't have documentation, and it's harder for you because you get that sense at the when things are going on, that you want to change your mind because you really don't want to let go because you're very sad. But that's why having that in place, even if it's in place. I have a friend who I worked with who her mom was very, very sick, and her dad but her mom was sick and acutely sick, where her dad had been sick for a long, long time. And her mom, and she knew, she was a nurse, intellectually she knew what the scenario would be. Her mother did not want to be resuscitated, and in my friend's mind, she knew it wasn't going to be helpful, because the end result, and that's it, the end result is, what is it going to be? That's always the question that you ask. And like I said about the gentleman who came in and we worked on him and he woke up, we knew what was wrong with him, and it was a reversible condition, and we reversed it. So, but for the most part, these are not reversible situations. And so I can remember her saying to me that as it got closer, as her mom got weaker and weaker, she said, I wanted to run out to that nurse's station and change the decision. And she said that she was an ICU nurse too. I mean, we know, intellectually we know we know things, but in our hearts, we're the same as anyone else because that is a personal situation. And so we can know it, but in our heart, we have, we still have the same conflicts. And she told me, and this was very poignant, it really left an impression. She said, I just had a nurse who sat me down and said, you know that the outcome is not going to be any different. Take a deep breath and let that sink in. Do you really want to do that to your mom? All right, so she used the guilt card a little. But my friend said to me, she was a blessing, because even though I had talked to my mom, even though we had the conversation, the paperwork was done, everything was there, I still wanted to change it. And she walked me down the path to keep everything in place. And I don't know how much longer after that her mom died. And to this day, it's been several years, and she's still very sad. And grief, everyone's grief is very unique, just like they are, and they have to work through it their own way. And sometimes you can get through it yourself, other times you need professional help, but that's okay. But she, to this day, will say to me, thank God for that nurse who recognized her panic and got her and said, the outcome is not going to be any different. So you don't want to do this. We're keeping her comfortable. You know that. As in your brain, you know that. So I know your heart hurts right now, but it's going to work out. And she went back and sat with her mom, and the inevitable did happen. And she talks about it, about wanting to change. But that one person, that nurse that intervened and said to her, come on, she said that made the difference. Just that it was the right decision. It made the difference. So, if there's anything that you could take away from my ranting, is please talk to your family, talk to your spouse, talk to your physician, get a primary care physician. It's important because they get to know you. Not only your lab numbers, not only what your blood pressure is, but they get to know you as an individual and your likes and your dislikes, and that's very important. So that's another topic, though. Gotcha. So anyway, it's, have the conversation, because you don't want to have it in crisis mode. It's one of the worst things that I have seen, and I've seen some really bad things. So take my plea and do with it what you may. Okay? So I'm Cathy Novicky for Champions Over Cancer. This is day 55 of 90 Days Live. Excuse me. And did I end before midnight? No. Ha! Okay. I'll see you today later. So I hope everyone's home, safe, tucked in, well, and I will see you tomorrow. Peace.